In the first part of this workshop now, we invite speakers to describe their experience and the actions implemented during the pandemic at different levels. First, the international organizations at global level, the EU member states, the national level, and health services at the local level. And so as an introduction, I would like to welcome our first speaker, Professor Luca Ragazzoni, who will provide a general introduction on disaster medicine, which is our big framework for today. So welcome, Professor. Thank you for being here. I give you the floor.
Thank you very much for the kind invitation. For me, it's a real privilege to introduce this workshop with my experience. For me, it has been a very difficult period since I'm a medical doctor, but now I'm currently managing a research center in disaster medicine and global health. And I'm really proud that we have been working throughout the pandemic, and we had our important efforts. This slide. So while I'm waiting for the slides, so my presentation is about our global challenges. I will show you different pictures that represents our current global challenges in terms of disasters and health crisis. So the first picture. How can I? Okay, next. So as you can see, the first picture represents the earthquake in the central Italy in 2016. So next. So the heat waves in Europe. These represent a picture from Paris in 2019, where we recorded at that time the highest temperature, that was 43 centigrade Celsius. Next. So the current drought, so is the Rhine in Germany. So also in Italy, also in my region, we are currently under a huge crisis in terms of drought. Next. Unfortunately, as we said before, the floods in Europe last year in 2021, these represent Belgium and the Meuse River. Next. The cyclone Idai in Mozambique in 2018. Next. The Ebola, the West Africa Ebola outbreak. I was there as I was the training manager of the biggest Ebola treatment center in Sierra Leone. Next. One of the the biggest non-nuclear blast in history is Beirut, August 2020. Next. Unfortunately, the current conflict in Ukraine. Next. The long-lasting conflict in Syria with important refugee crisis in the last decades. Next. And as you remember, in Brussels in 2016, the terrific terrorist attack in the airport and also in the center of Brussels. Next. All this scenario could define by an important definition made by the UN agency during the General Assemblies, where you can see that there are very important measures that we need to take in consideration, which are the hazard, the vulnerability, the exposure, and the capacity. From this formula, you can see how much is the current impact of the human factor. In fact, the most important thing that we should remember from now on, that we need to forget, we need to change our paradigm, because it's not the nature, it's our fault. So in fact, we should call them disaster caused by natural hazard. Next. So this is a very important paradigm that we need to change. And also through using that definition, we can clearly understand the COVID pandemic. Next. These are the numbers of and the impact of disasters at global level. As you can see, in the last 20 years, we have a sharp increase of the total number of disasters. And more than 1 million people died from disasters. And more than 4 billion people are have been affected by disasters. And also, as you can see from this picture, the most frequent disaster is flood and storm that are clearly climate related. And as you can see, there is a sharp increase from the previous 20 years for the climate related disasters. Next. And since the floods is the most frequent disaster, more than 1.6 million people have been affected by floods, and 1.43 billion people have been affected by drought. Again, as you can see, the climate-related action. The earthquake is the killer. So it's still the killer. So the 58% of the total deaths are caused by earthquake, are still the killer. But as you can see from the other graph, the heat waves in Europe have been one of the most frequent disasters and has caused more than 90% of the total deaths in the last 20 years. Next. And of course, disasters are increasing for the increase of our density, the urbanization. But the climate change is not only causing disaster-related, climate-related disaster, but all these factors have a huge impact on the emerging and re-emerging new infectious disease. And the coronavirus, the COVID-19, is an example of these issues that in the next future will be more evident. Next. Also, in terms of technological disaster, we had an increase in the last decades, mostly in the emerging countries, where it's difficult to manage the technology. Next. Also, in terms of conflict after the Second World War, we have a sharp increase of the so-called internal conflict at global level, mostly in the Middle East and in the sub-Saharan Africa. Next. And unfortunately, this increment of the number of conflicts all over the globe are causing more than 80 million forcibly displaced people around the world, where the 48 million are internal displaced population, people that are not passing the limit of their country, and more than 26 million are refugees. And as you can see, the 68% of these persons are coming from just 5 countries, and the 39% are hosted in 5 countries. These numbers are not counting the current crisis in Ukraine. Next. In terms of health effects, we need not to forget, we need to remember that there is not only the direct impact of disaster on the population, but we have indirect effect on population health. But not only, as we saw during the COVID-19, we have also to take into consideration the health system, the impact on the health system, the direct impact on the health system. For example, hospitals should remain functioning during disasters, but also indirect effect of disaster on the health system. Next. This is why it is important to remember and to advocate for disaster medicine, that we need to change the paradigm. It's not only about the health response. We are not focusing only in the clinical care of the population, but we need to remember that the health is throughout the disaster cycle, from the mitigation to the preparedness, response, recovery, and prevention. So, and the health is all over the disaster cycle, not only during the response. Next. And this is why we need to create a new profession, or at least to advocate for increasing the professionality in disaster health, which is a discipline that could comprise clinical care, public health, and disaster management. This is clearly was a gap during the COVID-19 response, where there were Ministry of Health that were working without the disaster management approach. Next. So therefore, I would like to close my presentation remembering that preparedness is not only about, in case of health crisis, public health infrastructure, but is also public health communication, risk communication, of course, the economic resources, the institutional capacity. We clearly understand during the COVID-19 the importance of the institutional capacities, and the physical infrastructure. But I would like to highlight one point next, that is not about, when we talk about health system, is not only about hospitals. And this was another gap during the COVID-19. It's about the primary care. It's about the pre-hospital care. It's about the public health working with the primary care, with the pre-hospital care, and the hospital. And of course, the government, the Ministry of Health that is managing the health system capacity. Next. These are an example on how the COVID-19 response was managed. An example from one of my friends in Taiwan, where they clearly stated that the success was a fast and proactive response, transparency, trust in policy making, frequent and effective communication, and technology, big data and technology. Next. And to close, we need to advocate, we must advocate for the Sendai framework for disaster risk reduction, and we must advocate for inserting health throughout the disaster management cycle, throughout the disaster risk management processes. Thank you very much.
Thank you, Professor, for your opening. I would just like for the audience to add your function because I omitted this in the beginning, you are scientific coordinator of the CRIMEDIM, the Center for Research and Training in Disaster Medicine, Humanitarian Health and Global Health, WHO collaborating center of the Università del Piemonte Orientale in Novara in Italy. And so thank you, and we will be back towards the end of our session with you. Professor Ragazzoni, who will make us happy by being the one wrapping up and giving the summary, and also very curious to hear your views on what you've heard today. And so I have also one question to you, and it's about middle income and low income countries, and how they relate to disasters, if they are usually more affected by it or not. This being a more general question from the audience, but I leave you in particular to give your assessment of today's discussion. Thank you very much.
So thank you very much for giving me the time to close. It's not easy after all this very nice and interesting presentation. So I would like first to change a bit my role, because I wanted very much to say a few more things, because something has not been said, and in my opinion it's very important to highlight. First of all, we have been talking about the scarce number of healthcare workers. So we lack of number of healthcare workers, but it's not enough. It's not only the number. So we need to train them. So we need to understand that at global level, within the medical school, within the nursing school, within the school of the health professionals, there is nothing about disaster medicine, global health, infection prevention and control. It's not about cultural awareness. It's about training. We need to train them. So it's a part of the curriculum, and it's not teach that. So we need to improve. So we need to go to the Ministry of Health, to the Ministry of University, and the Ministry of Education, and to advocate for the inclusion of disaster medicine principles, of global health principles, of infection prevention and control principles within the medical schools, within the nursing schools, within the health professional schools. So because we were not prepared, not because only for the numbers, because the healthcare professionals were not trained, were not well trained. So we saw the so-called just-in-time training. We must run a lot of just-in-time training, because the healthcare workers were not trained. They were not prepared to respond. Again, so it's not only about the numbers. Of course, the lack is of paramount importance, and it's very important what Raed Arafat said about the coordination at national level about the human resources, but why the people were not very well aware of probably coming from Cluj and going to Târgu Mureș or Bucharest to respond. Because if they are not trained to understand what does it mean disaster, it's difficult for them to accept. If we explain them that disaster is a moment where there is a total imbalance between the needs and the resource available, and there is a change of mindset, then the healthcare provider is written in the literature. If we train them, if we make them aware before, of course, they are more willing to respond. And another issue that is very, very important is that we didn't talk about the task shifting. There were healthcare providers that had to change their role. So from a dermatologist to go and treat the patient in sub-intensive care. Not intensive care, but at least sub-intensive care, or in COVID-19 patient. So what happened? That we, for example, in our experience, we run just-in-time training to train them to make this changement. But after the training, before the training, they will say, no, I don't want. I don't care. I don't want. After the training, so the list of people willing to change their role, so was unbelievable. Why? Because if you go back, when the healthcare workers start to think when they want to go to the medical school, it's about passion. It's about how to treat, how I want to treat the patient. But I want to be safe, and I want to be well-trained. If I'm well-trained, okay, I'm willing to do that. And this is what happened also during the Ebola response. So when I deployed to the Ebola response, I signed that my body, if I died, so my body could be rested there, okay? But I was aware of the risk. I was prepared of that. I was willing to do that because they were needed. And this is what happened also with the other healthcare workers. There were not a lot of healthcare workers willing to deploy in the Ebola response, or also local responders. When we trained the local responders, when we trained at the international level, the number of people, the number of humanitarian workers going to the Ebola response augmented a lot. Because we trained them. We make them aware. They were safe. They understand how to make them safe. That's it. Then it's going to go passion. I want to treat the patient. I want to save the life. This is the most important thing that we need to advocate. It's not only about numbers, but it's about training. This is the most important thing. The second point that I would like to highlight that was not mentioned is the primary care. Public health measure is not only about contact tracing, it's not only about surveillance, it's also about how the primary care is managed, the public health measure. Because at the very end, the people at home going to the family doctor, ask the family doctor how to behave. And then the primary care is key for any emergency. So now we have Ukraine. We are a little bit far, but if a bomb going to the biggest nuclear power plant, what happened? Is a public health incident, because it's not, you are not going to receive the amount of radiation, but it's how you remember during the Chernobyl. It's the same. So then it's a public health behavior. So we need to train the primary care system how to inform the patient. Of course, should be a national risk management, risk communication, of course. But then the patient call the family doctor, going to the family doctor. And if the family doctor works well on the nursing, sorry, not also the family doctor, but also the nursing, the other healthcare providers. So if they are working well, I'm closing, so if they're working well, they are not going to the hospital, and they are not going to the ICU. So the pandemic is not an ICU problem. Of course it was, but at the very end, it's not about the ICU. It's about the health system capacity, that it comprises the primary care, the pre-hospital care, the ambulance services, the public health measure, and of course the hospital. But the hospital is the last resources. We need to protect the hospital as a last resources. What happened in the low and middle income country? We have experience also there. We have managed, for example, the training at the national level in Sierra Leone because of an important project that we have created there. And we train the pre-hospital care system. We train the so-called healthcare workers at the rural level, okay? Because in low-income country, there are few doctors, few hospitals available. So you have to implement, you have to go there, you have to go to the rural area, okay? This was the key, or is still the key in low-income country. So to go and check, so to go in the community. It's more a community-based intervention rather than a hospital intervention. And finally, so I fully agree with Raed Arafat in terms of acute post-disaster amnesia. But it's not now. So in Italy, we had a tsunami. We had a tsunami at the beginning of the century. Every 2 years, we have an earthquake. And we have a post-acute, post-disaster amnesia every 2 years. It's not about now. Of course, now is a global issue. But any disaster, in any disaster, we have acute post-disaster amnesia. We need to change that. It's not only about preparedness. It's about prevention. It's about mitigation. Preparedness is one part of that. But before, we have prevention, mitigation, and of course recovery. Now, we need to build back better. This is the recovery. Build back better according to the SDGs. Otherwise, we are not going anywhere. Thank you very much.
Thank you.
What I miss here in political institution, we in scientific, we are working every time with risk probabilities. You work here in political life only, oh, it's very good, it's nothing wrong, it's going very well. No, you can have a crisis. You must be prepared for that. You must make a model of such a crisis. My another question I have, it's a very, very important one. You have the war in Ukraine now. You have the probability that Putin will use technical, tactical nuclear weapon. They are a very big health problem that you have. And nobody on the civil population has the idea what to do in this case. Is no indication. What are you doing in this case? That's my last question.
I would come to close. Would you like to still...
So I can reply very easily to the... in my opinion, so it's not only about politics. It's not also always about giving... So it's because of politics. In my opinion, here, so in emergency and disaster management, it's a problem of culture. Before going to the politics, it's a problem of culture. An example. Why the European civil protection is not close to the ACDC? Why the Italian civil protection are not fully equipped by health workers or medical doctors? It's a problem of culture. What you have just said about Ukraine, the possible public health issue, is about awareness, the culture of what is about. It's not about politics. It's about going first to create the culture, to create the knowledge about emergency and disaster, which should have an holistic approach. Health should be included. And when you create the knowledge, when the Ministry of Health will go to the Ministry of Health, they know that. But now they don't know. And nobody is teaching them.